Good afternoon. This is just a pilot study. It's not a large number of patients. So true chronic mesenteric ischemia is actually quite uncommon. It's called mesenteric angina, and it's characterized by abdominal pain after eating. Patients get weight loss. They get a fear of eating. The commonest cause is atherosclerosis, affecting the origins of the celiac trunk, the SMA and the IMA. And unfortunately, all older patients who come into hospital nowadays with any kind of tummy pains or a GI upset will get a CT scan. And they'll get a CT scan which discloses some atherosclerotic disease, and then they can get referred to the vascular surgical multidisciplinary team meeting, and we have to decide whether or not these patients might have chronic mesenteric ischemia. And most of the time they don't. If you take a very careful history and you talk to the patients, and you find that they've not really got that at all. But the problem is actually diagnosing it is quite difficult. Most patients, you can occlude at least one of your mesenteric vessels, and the supply to the gut will be taken over by the other mesenteric vessels. So you need to completely occlude at least one and probably stenose another one before you get chronic mesenteric ischemia. And we don't have low-risk interventions for this, so it's not a diagnosis we want to make likely. If we're going to do something to these patients, it's a potentially mortal operation, and even an angioplasty or a stent is potentially mortal as well in this scenario. So we don't want to treat patients with that don't actually need it. So, as I say, blood flow at rest in patients with chronic mesenteric ischemia is enough to keep the gut going, so they don't have complaints at rest. They have complaints when the gut is not at rest, i.e. after they've had food, and the gut wants more blood than can be delivered to deal with that food, and they therefore get ischemic pain. And the idea is, over the years, that we can confirm or refute mesenteric ischemia in response to a meal challenge. Just to say that an interesting thing is that the venous drainage of the gut is slightly actually simpler than the arterial supply to the gut, as in that all the gut drainage goes to the portal vein. And we'll come back to that in a moment. So as I say, older patients with CT often disclose abdominal vascular disease, but it's bystander disease that probably isn't actually causing any problems. And CTA gives no functional information. Ultrasound has been proposed for many years to look at response to a meal challenge, looking at flow rates in the SMA and the celiac trunk before and after a meal challenge, but it's a really difficult test to do. I've tried to do this on many occasions, and particularly after a meal, the gut gets very gassy and you just can't see the blood vessels. Contrast-enhanced MRA, just like CT, will show vessel occlusions, but it won't really give us much functional information. Phase contrast MRA has been advocated, but it's very, very time-consuming, especially for the branch of the celiac trunk, which is a vessel that immediately branches into several smaller branches. It's very difficult to place flow planes on that. There's also a problem in that the velocities that you're going to be looking at could be over 4 meters per second in the SMA. So you might end up doing many vessel scouts to try and get the right velocities. With 4D flow MRA, we can look at any vessel post hoc. Now, I was interested to see that Carsten Hoffman's presentation earlier on, that he was looking at right and left hepatic artery branches of the proper hepatic artery and the common hepatic artery and all these very small branches, because that's the kind of thing we didn't want to get involved with. We wanted something even simpler than that. And again, as I say, because you've got a very wide range of velocities in the arteries, you may end up having to do many acquisitions even with a 4D flow acquisition. So we decided that maybe the way forward was to image the portal venous flow, because it's one big vessel that's easy to see, and there's not much variation in the velocities in the portal vein. So we shouldn't run into problems with having to repeat our measurements to get different velocities in the portal vein. So our protocol was we took 6 healthy volunteers with no GI symptoms and no history that they should have any vascular disease, and 6 patients who we clinically strongly suspected did have chronic mesenteric ischemia, in that they had at least one vessel completely occluded on a prior imaging, either CTA or MRA, and another vessel stenosed. Obviously the patient cohort is older than the volunteer cohort. That's the characteristics of the patients here, was whether they all had weight loss, and most of them had at least pain after eating or an SMA thrombosis, weight loss. Sorry, they all had SMA thrombosis, but they had these other characteristics. The protocol was they were fasting for at least 6 hours prior to the test. They had anatomical scans with 2D flow, 4D flow, and, sorry, back to that, 4D flow. And then after that, they had 2 drinks of Ensure Plus of their choice, chocolate or banana or vanilla, whichever they wanted. We then repeated the imaging about 40 minutes after drinking the Ensure. We used a 3 Tesla Prisma scanner with a body array coil, and we used a 4D flow whip from Siemens. And these are the measurements we took with the 2D. We did above the celiac trunk, between the celiac trunk and the SMA, and below the renal arteries for the aorta. We also took 2D at the main portal vein, the proximal or the superior SMV, and the splenic vein prior to confluence to form the portal vein. These are the same planes that we took on the 4D flow. These are the parameters that we put onto our 4D flow acquisition. We then imported the data into a Siemens analysis post-processing package. This is just an example of doing the post-processing on one of these. So obviously the advantage of 4D is we can just plan one big block and we can then go in and analyze whichever planes we want afterwards, and get our velocities and make sure that we're actually true to the planes that we took with the 2D and match it all up. And we get the usual 4D flow kind of images that you're used to seeing in this meeting. And these are the results, a typical volunteer and a typical patient. So the volunteers, these are the flows before the meal and after the meal. There's a significant increase in flow, whereas in the patients with strongly suspected chronic mesenteric ischemia, there was this very blunted response with not much increase in flow following the meal challenge. This is the groups. As I say, there's only n equals 6 in each group, so they're not particularly large groups, but we do have a significant result for some of these values here, particularly for the portal vein and for the SMA between the volunteers and the patients. This is a Bland-Altman plot showing the differences between the 2D and 4D flows, quite good correlation. So our conclusion was that we can show a measurable hemodynamic response to a meal challenge in the portal vein, the SMV and the SMA compared to in normal healthy volunteers, and in the patient cohort these response was completely attenuated. So it has validated our 4D flow versus the 2D was a good agreement. Obviously it is a small pilot study and we need to get some money together to properly look at a larger cohort of patients, because what we really want to do is find the patients that we don't think have got chronic mesenteric ischemia and show that they don't have this blunted response that we've shown in the patients that we think really do have this condition. Thanks for your attention.